This video will review the Minnesota tube and its placement when medical therapy is not sufficient enough to control an upper GI bleed thought to be from gastric or esophageal varices while awaiting more definitive management. Within our Minnesota tube kit, you will find the Minnesota tube itself, a TUI syringe, a Christmas tree connector, various stopcocks, and also a cufflator, which will allow you to inflate the balloons and also measure the pressure within inside them, and a scissors, which you can use to cut the tube if you need to emergently remove the tube and deflate them. You will also find mosquito clamps, which I have already pre-taped, which you will need to do to prevent damage to your Minnesota tube. The Minnesota tube has 6 ports in total. It has a pair of ports, which are for aspiration of the stomach and the esophagus, and these can be hooked up to wall suction via the Christmas tree connector to aspirate their contents. You also have a pair of ports, which is for the gastric balloon. These ports allow for inflation of the gastric balloon, and you can also use a port to measure the pressure within the gastric balloon. You also have the same setup for the esophagus in that you have a balloon port, and you also have a port that you can use to measure the pressure within the esophagus. You'll notice these ports are covered with caps, which you'll need to replace with stopcocks if you plan on accessing them.
On the tube, you'll find markings up to 50 centimeters. And within the tube, you'll find ports for suctioning from the esophagus, aspiration port. You'll find the esophageal balloon. You'll find the stomach balloon, and also ports for aspiration within the stomach.
Next, you'll want to check the balloon to ensure there's no leaks within both the esophageal and the gastric balloon. Here you'll see that I'm inflating the gastric balloon with air and submerging it underwater to ensure there's no air leakage. Given that there's no bubbles coming from the balloon, we know it's safe to use. You can then deflate the gastric and esophageal balloon and prepare for insertion in your intubated patient. Prior to inserting the tube, you'll want to lubricate the balloon with lubricating jelly.
Once you're ready to insert the tube, consider measuring the depth that the tube needs to go for your patient. You can measure from mouth to ear all the way down to subxiphoid process. Generally 50 centimeters, which is the last marking on here, is sufficient for most patients. Once you're ready to do that, the first tube you want to blow up is your gastric tube. So you can identify your gastric ports. I have 2 stopcocks already placed on them, both turned off to the tube. And then you want to first insert 50 cc's into the gastric tube. Once you've inserted 50 cc's, turn the stopcock back off to the patient. At this point, I'd recommend getting an x-ray to ensure you're actually in the stomach. If you're in the stomach, you can continue to inflate another 400 to 450 cc's of air into the tube. Throughout the process, if you feel the tube could have moved or if you want to double check pressures, you can always hook up the manometer or the cufflator to the other port. It hooks up very easily, just screws in. And at this point, you can actually just turn the stopcock on to the cufflator. And it gives you a reading of the pressure within the tube. It's going to be around 40 millimeters of mercury or so. You can always test this while it's outside the patient. It should never be more than 15 millimeters of mercury above your testing pressure. Having tested this, ours is going to be around 30 to 40 millimeters of mercury. Once you've done that, ideally your tube is in the right place. You can get an x-ray to confirm. Once you've confirmed proper placement, next you have to apply traction.
Here you'll see that I'm placing traction on the Minnesota tube by using a roll of Kerlix. I'm just placing a knot around the end of the Minnesota tube, which I will then attach to a IV pole attached to the patient's bed, and then lastly tie the other end to a liter of saline, giving you 1 kilo of pressure. You could also attach the tube to a football helmet, which we do have available in our department. Ideally, you've controlled hemorrhage with the gastric balloon. However, if the patient continues to bleed, you'll need to inflate the esophageal balloon. Here I am adding stopcocks to the ports connected to the esophageal balloon. What you'll want to do is inflate the balloon to a pressure of about 40 millimeters of mercury max. To do this, you'll use your cuff flater and attach to your esophageal balloon, which you can use as a pump to inflate the balloon. Ideally, this is only going to be a small volume, but while doing this, you'll want to watch your pressures to ensure you're not inflating the balloon to more than 30 to 40 millimeters of mercury. With hemorrhage control at this time, you can use your forceps to clamp the esophageal balloon and also the gastric balloon to prevent any air leakage. Keep your stopcocks in place and also keep them capped to also prevent any air leakage. Lastly, after these are clamped, you can replace your Christmas tree connector to the aspiration ports of the stomach and esophagus to suction contents and lavage as needed.